Imagine just walking into your patient's room for a second. Your patient is 6 months old.
Okay, set in the scene.
Yeah, so they woke up hungry and they're crying.
Yeah.
But within seconds, this isn't a normal cry at all. Right before your eyes, their lips, their nail beds, their skin, it all turns this deep, terrifying shade of blue.
Oh, that is a total nightmare scenario.
You're right. They are hyperventilating, they're panicking, and as a nurse, you have like maybe 3 seconds to understand the incredibly complex structural plumbing of their heart.
They really do.
You have to formulate a physiological counterattack, basically, and intervene before that child loses consciousness.
And that is exactly the moment that tests everything you know. I mean, you can't just rely on memorized flashcards when a baby is turning cyanotic right in front of you.
No, absolutely not.
You have to be able to sort of see through their chest, visualize those pressure gradients, and know exactly which way the blood is flowing.
Which brings us to the exact mission of our deep dive today.
Hmm.
So welcome. We know exactly who you are, and we know what is sitting on your desk right now.
Probably a massive pile of highlighters and notes.
Exactly.
Yeah.
You are a nursing student staring down a massive, super intimidating pediatric nursing final exam. You are just swimming in an ocean of congenital heart defects, chemo protocols, neuro assessments, developmental psych, all of it.
That is so much material.
It's overwhelming. But today, we are tossing the flashcards. We're going to transform that incredibly dense list of facts into a vivid, logical, clinical picture for you.
Because memorization is fragile, right? It breaks under pressure.
It totally does.
But understanding the physiological why and how is what makes you resilient at the bedside. When you really get the underlying mechanics of a disease, the nursing interventions don't just become, things you have to do.
Yeah.
They become the only logical things you actually can do.
Okay, let's unpack this. We're going to start this journey at the literal heart of the matter. We need to talk about congenital heart defect.
A huge topic on the exam.
Oh, massive.
Yeah.
But before we get into the alphabet soup of ASDs, VSDs, and PDAs, we really need to establish the ground rules of the heart.
Because a baby's heart operates on a very strict set of physical laws.
Right. So what is the core principle here?
The single most important rule of pediatric cardiac defects, and honestly of fluid dynamics in general, is the concept of pressure gradients.
Pressure gradients.
Okay, right. Think of it this way. Blood is inherently lazy.
Lazy blood. I like that.
It's true. It will always, always flow from an area of high pressure to an area of low pressure. It just takes the path of least resistance.
So if you could remember that one rule, you can basically decipher almost any cardiac defect.
Exactly. So let's map out that high and low pressure in a normal, healthy heart first.
Okay, lay it out for us.
Well, think of the left side of the heart as the heavy lifter. The left ventricle has a massive job.
Because it comes to the whole body.
Right. It has to pump oxygenated blood out through the aorta, all the way up against gravity to the brain, and all the way down to the tips of the toes.
Overcoming all that vascular resistance.
Exactly. Because of that insane workload, the muscle wall of the left ventricle is really thick. It's robust, and it operates under extremely high pressure.
It's like the bodybuilder of the heart.
That is a perfect way to put it. Now look at the right side of the heart.
The right side is a bit lazier.
Yeah, kinda. The right ventricle only has one job pump deoxygenated blood next door to the lungs.
And the lungs are right there.
Right there. And they are a low-pressure, spongy system. The right ventricle just doesn't need to push very hard.
So the muscle wall is thinner.
Yes, and the pressure on the right side of the heart is significantly lower than on the left.
Okay, so high pressure on the left, low pressure on the right. That's the baseline.
That's your baseline normal.
So what happens when there is a structural mistake? Like what if a baby is born with a hole in the wall, the septum, that divides that high pressure left side from the low pressure right side?
Well, our fundamental rule takes over. Blood takes the path of least resistance.
The lazy blood.
Exactly. When the heart squeezes, instead of all the blood on the left side taking that difficult high-pressure path out to the body, a significant portion of it just finds that hole.
It escapes.
It totally escapes. It flows right through the hole from the high-pressure left side back over to the low-pressure right side. We call this a left-to-right shunt.
A left to right shunt. And the critical thing for a nursing student to picture here is the color of that blood, right?
Yes, the color is key for understanding the clinical presentation.
Because the blood on the left side of the heart has already been to the lungs. It is fully oxygenated. It's bright red.
Right.
So when it shunts back to the right side, it's basically just oxygenated blood going back for a totally unnecessary second trip to the lungs.
Which is why these specific defects are categorized as acyanotic. The baby does not turn blue.
Right. A meaning without, and cyanotic meaning blue.
Exactly. The blood going out to the body, at least whatever manages to make it out, is fully oxygenated.
So the problem isn't a lack of oxygen then?
No, not at all. The problem is extreme mechanical inefficiency. The heart is doing double the work for half the result.
Okay, let's break down the big three defects that cause this left-to-right shunt, which creates increased pulmonary blood flow. The atrial septal defect, the ventricular septal defect, and the patent ductus arteriosus.
The big three.
Let's hit the holes in the wall first, the ASD and the VSD.
Sure. So an atrial septal defect, or ASD, is a hole in the upper chambers of the heart, the atria. Blood shunts from the left atrium back to the right atrium.
And then a ventricular septal defect, the VSD, is a hole in the lower pumping chambers, the ventricles.
Right. And you have to realize a hole in the ventricles is usually much more dramatic than a hole in the atria.
Because the atria are mostly just these passive filling chambers, right? But the ventricles are the main engines.
The main engines, exactly. The pressure differential between the ventricles is immense.
So when the left ventricle contracts, it generates huge force.
Right, and if there is a VSD, a massive volume of that freshly oxygenated blood blasts right back through the hole into the right ventricle.
Wow, so the right ventricle is suddenly dealing with its normal volume of blood plus this huge extra tidal wave from the left side.
Yes, and it has to pump all of that extra volume directly into the lungs.
That sounds exhausting for the lungs. Which actually brings us to the third acyanotic defect, which isn't a hole in the ventricular or atrial wall at all.
Right, this one is different.
It's an external vessel that refuses to close. The patent ductus arteriosus, or PDA.
This is a classic exam topic.
Definitely. I really want to visualize this anatomy for everyone listening, because exam writers love this one. If we think of the aorta as the high-pressure interstate superhighway, delivering bright red oxygenated blood to the whole body.
Okay, I see where you're going.
And the pulmonary artery is the low-pressure kind of local dirt road, taking blue deoxygenated blood just to the lungs. And open PDA basically means there's a rogue connecting off-ramp between them, right?
That is a perfect analogy.
Thank you.
No, really, because all that high-speed, high-pressure traffic on the aortic superhighway sees this little off-ramp connecting back to the low-pressure pulmonary road.
And the lazy blood takes it.
It takes the easy way out. It loops right back into the lungs. But to really grasp a PDA, you have to understand why that off-ramp is even there in the first place.
Right, because it's not actually a structural mistake, is it?
It's a leftover piece of fetal survival gear.
Because in the womb, a baby doesn't use its lungs to breathe.
Exactly. The mother's placenta is doing all the heavy lifting. It does all the work of oxygenating the blood.
So what are the baby's lungs doing?
The fetal lungs are essentially collapsed. They're fluid-filled, and they are incredibly resistant to blood flow.
High pressure.
Very high pressure.
Yeah.
So the fetal heart has this genius little bypass vessel, the ductus arteriosus.
It connects the pulmonary artery directly to the aorta.
Right. It allows the blood to bypass those useless fetal lungs entirely and go straight out to the developing body.
But the moment that baby is born, everything has to change instantly.
It happens so fast. The baby takes its first breath. The lungs expand with air.
And that resistance drops.
The resistance in the pulmonary vessels drops to almost nothing. Suddenly, the lungs are the low-pressure zone.
Okay, so normally, what's supposed to happen to that off-ramp?
Normally, within hours to days after birth, the body recognizes this pressure change. It recognizes the higher oxygen levels in the blood, and the ductus arteriosus naturally clamps shut. It just becomes a tiny ligament.
But if it fails to close, if it remains patent, you have a PDA.
Yes. And now the pressure dynamics are totally reversed from when the baby was in the womb.
Right, because now the aorta is the high-pressure zone.
Right.
And the lungs are low pressure, so the blood runs backward through that open duct.
It does.
So as a nurse, what does this actually sound like when you put your stethoscope to that baby's chest?
Oh, it is unmistakable. You will hear a continuous machine-like murmur.
Machine-like.
Like a washing machine.
Literally sounds like a washing machine churning. You hear it best at the left upper sternal border. Why is it continuous, though? Most murmurs have a rhythm, right?
Because the pressure in the aorta is higher than the pulmonary artery during both systole, when the heart squeezes, and diastole, when the heart relaxes. The blood is just constantly rushing through that tunnel.
Okay, the clinical presentation of a PDA also includes something called a wide pulse pressure and bounding pulses.
Yes, that trips up a lot of students.
Let's really unpack the wide pulse pressure, Because that concept is guaranteed to be on the exam.
Sure. So pulse pressure is simply the mathematical difference between your systolic blood pressure, the top number, and your diastolic pressure, the bottom number.
Okay. So in a baby with a significant PDA.
The left ventricle is working incredibly hard to pump extra blood, right? It's trying to make up for all the blood that's being lost down the off-ramp.
Right.
So the systolic squeeze is super strong, the top number is normal or even high.
But then the heart relaxes.
Exactly. When the heart relaxes during diastole, the aortic valve closes. Normally, the blood in the aorta just stays there, maintaining a decent baseline pressure.
But with a PDA, there is a leak.
A huge leak. All that blood in the aorta suddenly runs off backwards through the PDA and into the lungs.
Oh, wow. So because the aorta empties out so quickly during the resting phase, the diastolic pressure just plummets.
It plummets. So you have a high top number and an incredibly low bottom number. The gap between them widens.
And that wide gap is the wide pulse pressure.
Exactly. And that massive sudden swing from a high-pressure squeeze to a low-pressure runoff is what creates that forceful, bounding pulse you feel when you touch the infant's brachial or femoral arteries.
It's like a water hammer.
Literally.
All of this extra blood looping back has a devastating consequence on the lungs, though. They are basically getting flooded.
The lungs become completely congested, the pulmonary vessels are totally engorged, the fluid starts to leak into the air sacs.
So the infant develops tachypnea.
Right. Rapid, shallow breathing. Their lungs are stiff and heavy. They're working incredibly hard just to draw a single breath.
And when breathing is an intense workout, eating becomes impossible.
Think about trying to run a marathon and eat a cheeseburger at the exact same time. You can't do it.
Yeah.
These infants will start to feed, get exhausted, start sweating profusely from the exertion, and just stop eating.
So they don't take in enough calories, but they're burning thousands of extra calories just trying to breathe and pump their failing heart.
It's a vicious cycle. The ultimate clinical result is failure to thrive. They simply stop growing.
Okay, so we have a flooded lung system, an exhausted baby, and an open off-ramp. How do we close it?
We have to look at the chemistry of the off-ramp. The vessel is kept open by a chemical in the body called prostaglandins.
Prostaglandins.
Yes. So if we can block the production of prostaglandins, the vessel will constrict and close on its own.
What's the medication for that?
The first-line medical treatment, especially in premature infants, is to administer an NSAID, a non-steroidal anti-inflammatory drug. Usually indomethacin or sometimes ibuprofen.
Because they block prostaglandins.
Exactly. They are powerful prostaglandin inhibitors.
And what if the indomethacin just doesn't work?
Then we move to procedural interventions. A cardiologist can go into the cath lab, thread a catheter up through the femoral vein, and place a tiny coil or plug directly into the PDA to block it.
Just plug the hole.
Right. Or if the anatomy doesn't allow for that, a surgeon will actually perform a ligation. They physically tie a suture around the vessel to close it off.
Okay, let's summarize this first category real quick. Left to right shunts. The ASD, VSD, and PDA. The blood flows from the high-pressure left side back to the low-pressure right side.
Yes.
The baby is acyanotic. They're pink. But their lungs are drowning in excess blood flow, leading to extreme fatigue, poor feeding, and heart failure.
That's the perfect summary.
But as complex as that is, the plumbing is still fundamentally flowing towards the lungs. What happens when the plumbing is so mangled that the pressure gradients entirely flip?
That's when things get really scary.
Right, like what happens when deoxygenated blood bypasses the lungs entirely and heads straight out to the body?
That plunges us into the category of cyanotic defects. These are the defects that cause decreased pulmonary blood flow.
Okay, and for the exam, what are the primary ones we need to master?
The ones that begin with the letter T, the rule of T.
T for trouble.
Exactly. Tetralogy of Fallot and tricuspid atresia.
Let's tackle tetralogy of Fallot first, or TOF. Tetra means 4. So there are 4 distinct anatomical disasters happening simultaneously in this one heart. Walk us through the puzzle.
Tetralogy of Fallot is basically a brutal domino effect. Defect number 1 is pulmonary stenosis.
Meaning narrowing.
Right. The pulmonary valve, the door leading out of the right ventricle into the pulmonary artery and the lungs, is stiff, narrowed, and refuses to open properly. It creates a massive bottleneck.
So the right ventricle is trying to pump blood to the lungs,
Okay,
the door is jammed shut.
Exactly. Which leads to defect number 2, which is the direct result of that jammed door right ventricular hypertrophy.
Because it's working so hard.
Just like a bodybuilder lifting heavy weights every day, the right ventricle has to squeeze with unbelievable force to push any blood past that stricture, so the muscle wall thickens, hypertrophies, and gets huge.
Okay, so we have a bottleneck and a massive right bicep of a ventricle. What are the other two defects?
Defect number 3 is an overriding aorta.
Overriding. What does that mean?
Normally, the aorta is positioned neatly over the left ventricle, ready to receive oxygenated blood. But in TOF, the aorta is shifted. It slides over and sits directly above the ventricular septum, the wall between the ventricles.
And it just so happens there's a hole in that wall.
Yes. Defect number 4 is a ventricular septal defect, a VSD, a large hole right beneath that shifted aorta.
Wow. Okay, let's put this entire anatomical nightmare into motion for everyone listening. The massive right ventricle contracts. It's trying to send blue, deoxygenated blood to the lungs, but it hits the brick wall of the pulmonary stenosis.
Right.
So the pressure inside the right ventricle skyrockets.
It skyrockets so much that it actually becomes higher than the pressure on the left side of the heart.
And that is the critical turning point, right?
Yeah.
The pressure gradient flips.
Yeah. It totally flips. Now, the right side is higher pressure than the left. The blue deoxygenated blood is just looking for the path of least resistance.
And it cannot get through the pulmonary valve.
No. But right next to it is a giant hole, the VSD, and an open aorta sitting right on top of it, essentially rolling out the red carpet.
Oh, man. So the blue blood says, I'm taking the easy way out. It shoots across the VSD, completely bypassing the lungs, enters the aorta, and gets pumped out to the entire body.
And that is a right-to-left shunt. Oxygen-poor blood is flooding the systemic circulation.
So the physical result is profound cyanosis.
Very profound. The baby's skin, lips, and mucous membranes turn a dusky blue.
This mechanism right here brings us back to the clinical scenario we opened the episode with, the TET spell, or hypercyanotic episode.
Yes, this is a life-or-death nursing emergency and a guaranteed exam topic.
Let's break down the exact bedside physiology of why a TET spell happens.
A TET spell is triggered by an acute, sudden increase in the resistance to pulmonary blood flow.
Okay, so going back to our 6-month-old, they wake up hungry, and they start to cry.
And crying is a massive exertion for an infant. It dramatically increases the pressure inside the thoracic cavity.
They're essentially bearing down.
Yes, exactly. That increased pressure in the chest momentarily clamps down even harder on the already narrowed pulmonary outflow tract.
So the bottleneck goes from bad to absolutely impenetrable.
Right. Plus, spasms can also occur in that infundibular muscle right below the pulmonary valve.
The door to the lungs just slammed, completely locked.
The resistance to the lungs goes infinitely high. Consequently, almost 100% of the blood in the right ventricle is forced across the VSD and out into the body.
Oh, wow. So the oxygen saturation in the baby's body just plummets at a terrifying rate.
The baby becomes deeply, profoundly cyanotic. They gasp for air, hyperventilating in a desperate attempt to get oxygen that simply cannot reach their blood.
And if that cycle isn't broken.
The severe hypoxia leads to limpness, seizures, and eventual cardiac arrest.
Okay, so as the nurse standing at that bedside, your first intervention is physical. The study guide says to immediately put the infant in a knee chest position.
Yes, immediately.
Or, interestingly, earlier toddlers with unrepaired TOF will actually spontaneously drop into a deep squat on the playground when they feel a spell coming on.
It's an incredible survival instinct.
Let's unpack this. Why does folding a child up like a pretzel save their life?
This is honestly one of the most elegant examples of manipulating physics in medicine. We have to reverse the pressure gradient.
Because right now, the right side is high pressure and the left side is low pressure.
Right, so blood flows right to left. We need to make the left side high pressure again to force the blood back the other way.
How does bringing the knees to the chest do that?
When you forcefully bring the knees tightly up to the chest, you physically kink the femoral arteries in the groin. And those are massive conduits for blood flow to the lower body.
It's like stepping heavily on a flowing garden hose.
Exactly like that. You block the flow. By kinking those huge arteries, you instantly and massively increase the resistance in the entire systemic circulation. The systemic vascular resistance, or SVR, shoots through the roof. The pressure in the aorta skyrockets.
And now, the blue blood in the right ventricle looks at the VSD, looks at the aorta, and says, whoa, there is way too much pressure over there now. I can't go that way.
The path of least resistance has shifted back. The immense pressure in the aorta acts like a wall, blocking the right to left shunt.
So the blood in the right ventricle is forced to turn around.
It has to push its way through that spasming pulmonary valve into the lungs to finally get oxygenated.
Wow. So the knee-chest position forces the blood to the lungs by essentially weaponizing systemic resistance.
That's exactly what it does.
That is the level of understanding that turns a panicked nursing student into a calm, competent clinician. Okay, so while they are in the knee-chest position, you are also calling for help and administering 100% oxygen.
Right. Now, the oxygen won't fix the anatomical shunt, but whatever minimal blood is managing to squeeze into the lungs needs to be maximally saturated.
Makes sense.
Okay.
And you also administer IV fluids.
Yes, to expand their blood volume and decrease the viscosity of their blood so it flows a bit easier.
And then the physician will order morphine.
Morphine is key here.
See, administering a heavy narcotic to a baby who is hyperventilating and cyanotic feels incredibly counterintuitive. Why morphine?
I know, it feels wrong, but morphine is a dual-action lifesaver in a TET spell.
How so?
First, it is a potent sedative. It stops the crying, it stops the panic, and it dramatically lowers the infant's metabolic demand for oxygen.
Okay, that makes sense.
Second, and critically, morphine actually helps break the spasm of the right ventricular outflow tract.
Oh, really?
Yes, it relaxes the infundibular muscle, opening the pulmonary door just a fraction more. Plus, it suppresses the respiratory center in the brain.
Which stops that dangerous hyperventilation that was actually worsening the chest pressure. Okay, let's talk about the long-term management before this child can get to the operating room for a full repair. The guide mentions a medication that, on the surface, feels like a massive contradiction to what we learned 10 minutes ago. Prostaglandin E1.
Oh, Prostadil. This is a beautiful example of how pediatric cardiology uses the body's own flaws against it.
Because, wait, remember the patent ductus arteriosus. In a normal baby, or an acyanotic baby, we used indomethacin to block prostaglandins and force that off-ramp to close so the lungs wouldn't flood.
Right, we absolutely wanted the PDA closed.
But now we are giving prostaglandins.
Imagine a newborn with a severe form of petrology of Fallot. Their pulmonary valve is completely obstructed. Practically zero blood is getting from the right ventricle into the lungs.
The front door to the lungs is permanently locked.
If the front door is locked, they will die unless we can find a back door.
Ah, and the patent ductus arteriosus is the back door.
Yes. It connects the aorta to the pulmonary artery. In a severe TOF baby, we intentionally administer continuous IV prostaglandin E1 to keep that fetal ductus arteriosus wide open.
So the blood bypasses the lungs via the VSD, enters the aorta, but then some of it finds the open PDA and sneaks back down into the lungs to get oxygenated.
Exactly. It's a literal lifeline. It provides just enough pulmonary blood flow to keep the infant alive until the surgeon can perform a shunt procedure or a complete repair.
Let's briefly touch on the other T before we move on. Tricuspid atresia.
So atresia means the absence of a normal body opening. In tricuspid atresia, the tricuspid valve, the door between the right atrium and the right ventricle, completely fails to develop in utero.
It's just a solid wall of tissue.
Yes, it's totally blocked.
So the blue blood returns from the body into the right atrium, and it literally has nowhere to go. It hits a dead end. How does a baby survive birth?
They absolutely must have an atrial septal defect, a hole in the atria.
Otherwise, the blood is just stuck.
Right. All of the blue blood in the right atrium is forced across the ASD into the left atrium, where it completely mixes with whatever red oxygenated blood is returning from the lungs.
And then what?
This mixed purple blood then goes down to the left ventricle and out to the body. These babies are profoundly cyanotic and require immediate staged surgical reconstructions to essentially bypass the right side of the heart altogether.
Okay. We have covered left to right and right to left shunting. The plumbing is leaking. Now let's explore what happens when the plumbing is physically blocked or disastrously backwards.
The obstructive and mixed defects.
Let's start with the blockages. The classic example here is coarctation of the aorta, or CoA.
Coarctation just means a stricture or a narrowing.
Where is it usually located?
Well, the aorta leaves the left ventricle, arches up over the heart, sends branches up to the head, neck, and arms, and then makes a U-turn and travels down through the abdomen to supply the lower half of the body.
Okay.
In a coarctation, there is a severe localized pinch point in the aorta. It usually occurs right at the curve, just past the branches that feed the upper body.
Let's bring back our garden hose analogy.
Good idea. The left ventricle is pumping with enormous force. That massive wave of high-pressure blood rushes up the aorta and suddenly hits this severe pinch point.
So all of that immense pressure backs up.
Yeah.
And where does it back up into?
It backs up into the branches that lead to the upper body before the pinch. The head, the neck, and the arms are subjected to incredibly high blood pressure.
Which creates a very specific mechanical clinical picture. I imagine the child is really feeling that pressure up top.
They are. The infant or child will have pounding headaches, frequent spontaneous nosebleeds due to the high pressure in those fragile nasal capillaries.
And when you feel their radial pulses in their wrists, they will be bounding and forceful.
Yes, but think about what happens past the pinch point.
The lower body.
The blood trying to get to the lower body is reduced to a weak trickle. The lower half of the body is totally starved for oxygen and flow.
So the legs will be cool to the touch.
Cool, pale. And an older child might complain of severe cramping or pain in their legs when they try to run or play, a condition called claudication.
And from a nursing assessment standpoint, this is the entire reason why performing four-extremity blood pressures is a mandatory protocol in newborn care, right?
Absolutely. If you take a blood pressure on a newborn's right arm, and it is, say, 90/50, and then you wrap that cuff around their leg and the pressure is 60/30.
Alarm should be ringing in your head.
A huge red flag. A significant pressure differential between the upper and lower extremities is the hallmark diagnostic sign of a coarctation.
Furthermore, when you attempt to palpate the femoral pulses in the groin, they will be profoundly weak or delayed compared to the radial pulse, or even entirely absent.
Yes, that delay is very characteristic.
Treatment usually involves going into the cath lab with a balloon to forcefully dilate that narrowed segment, right? Or a surgeon will go in, literally cut out the pinched segment of the aorta and sew the two healthy ends back together.
Exactly. Let's move to the other obstructive defects, aortic stenosis and pulmonic stenosis.
Okay.
These are straightforward mechanical limits. The valve itself is thick, rigid, and fused. It just won't open all the way.
Like trying to evacuate a crowded theater through a single door that's only open a few inches.
Yes. With pulmonic stenosis, the right ventricle has to hypertrophy to force blood to the lungs, eventually leading to right-sided heart failure.
And with aortic stenosis.
The left ventricle hypertrophy is trying to force blood out to the body. Aortic stenosis is incredibly dangerous because it severely caps the heart's ability to increase cardiac output.
If that child goes out and tries to sprint across the soccer field, their body demands a massive increase in oxygen. But the aortic valve simply won't let any more blood through.
Right, the heart is working furiously, but the blood can't escape. The coronary arteries themselves become starved for oxygen.
So the child will experience crushing chest pain, profound fatigue, and they are at extremely high risk for syncope fainting or even sudden cardiac death during exertion.
So the strict nursing intervention for a child with known severe aortic stenosis is absolute activity restriction. No competitive sports, no heavy exertion.
Until a cardiologist can perform a balloon valvuloplasty to forcefully crack those fused valve leaflets open.
Exactly. It is a physical, mechanical limitation that sheer effort cannot overcome.
Okay, we are moving to the final cardiac category, mixed defects. And the one that consistently breaks the brains of nursing students is transposition of the great arteries, or TGA.
Oh, this one is a mind bender.
The two major vessels, the aorta and the pulmonary artery, are completely swapped.
It is a structural catastrophe. The aorta, which is supposed to take red blood to the body, is attached to the right ventricle.
And the pulmonary artery, which is supposed to take blue blood to the lungs, is attached to the left ventricle.
The plumbing is perfectly backwards.
Think about the nightmare this creates. It forms two utterly separate closed-loop circulations that never interact.
Yes. Loop 1. The right ventricle pumps blue, deoxygenated blood out the aorta to the body. The body extracts whatever tiny bit of oxygen is left, and the very dark blue blood returns to the right atrium, then the right ventricle, and gets pumped right back out to the body.
A closed loop of hypoxia.
Exactly. And loop 2. The left ventricle pumps red, highly oxygenated blood out the pulmonary artery into the lungs. The lungs pack it with more oxygen, it returns to the left atrium, left ventricle, and gets pumped right back to the lungs.
A closed loop of perfectly oxygenated blood that never goes anywhere useful.
Exactly.
If the oxygenated blood never ever reaches the body, how is it physically possible for a baby with TGA to survive even a single minute after the umbilical cord is cut?
They cannot survive unless there is a mixing point.
A mixing point.
There must be an anatomical flaw, a hole, that allows those two isolated loops to cross-contaminate. If the baby is born with a VSD or an NSD, some of the red blood from the left side will mix into the right side and reach the body.
So once again, we are running to the med room for prostaglandin E1.
Immediately upon birth, you must initiate a prostaglandin E1 infusion to prevent the ductus arteriosus from closing. You have to keep that back door open to allow oxygenated blood from the pulmonary artery to mix into the aorta.
But the prostaglandin isn't always enough to provide adequate mixing.
It isn't. Often the baby will be rushed to the cardiac cath lab for an emergent life-saving procedure called a balloon atrial septostomy.
What exactly do they do?
A cardiologist threads a catheter with a deflated balloon at the tip into the right atrium, pushes it straight through the atrial septum into the left atrium, inflates the balloon, and violently yanks it back.
They intentionally tear a hole in the heart wall.
They rip open a massive ASD.
Wow.
It guarantees that the red and blue blood will mix freely, providing just enough oxygen to the body to keep the infant alive until the surgeon can perform the ultimate fix.
Which is the arterial switch operation, where they physically detach the great vessels and sew them onto the correct ventricles.
Yes.
The other mixed defect to note is truncus arteriosus. Instead of two separate arteries, the embryological tissue never divided.
There is just one massive single trunk, leaving the heart, straddling a large VSD, receiving a complete chaotic mix of blood from both ventricles.
The baby will be cyanotic, have heart failure, and requires major reconstructive surgery.
It's all about ensuring that mixed blood gets properly routed eventually.
All right. We have covered the complex anatomical plumbing. We know the pressure gradients. But knowing the anatomy is only half the battle.
It really is.
The exam and your entire nursing career will focus heavily on how you actually manage these fragile patients at the bedside. Let's explore the art of cardiovascular nursing.
The bedside management of a pediatric cardiac patient is incredibly precise. Let's start with cardiac catheterization care, because whether a child is getting a diagnostic workup, a balloon dilation, or a device closure, they will all come back to your unit post-CAS tray.
Okay, so the catheter is almost always inserted into the femoral artery or vein in the groin. When that child rolls back onto the floor, what are the immediate life or death nursing priorities?
Number one is the insertion site. The femoral artery is a massive vessel operating under high systemic pressure.
So if that clot pops,
The bleeding isn't a slow ooze. It is sudden, arterial, and catastrophic. You are assessing that dressing frequently for active, frank bleeding.
but bleeding isn't always visible on the dressing.
No, it's not. You must palpate the area. If you feel a hard, expanding lump under the skin, or if the groin is suddenly swelling and turning purple,
The artery is bleeding internally into the tissue.
yes, that is a massive hematoma, and it requires immediate manual pressure, literally putting on a glove and pressing down hard with your body weight and calling the physician.
To prevent that clot from popping in the first place, the study guide highlights a crucial positioning rule.
You must keep the affected leg completely straight and immobilized, usually for 4 to 6 hours, depending on whether they accessed an artery or a vein.
If the child bends their hip,
The mechanical shear force will dislodge the clot.
which is incredibly difficult with a 2-year-old.
Oh, it's nearly impossible. You might need to use a knee immobilizer splint. You will rely heavily on the parents to read books, play videos, sing songs, whatever it takes to enforce strict bed rest.
You also have to assess the circulation downstream from the insertion site.
You are checking the pedal pulses, the pulses on the top of the feet, and you must check them bilaterally. Compare the pulse on the calf leg to the pulse on the unaffected leg.
If the pulse on the calf leg is absent, or if that foot is suddenly pale, cold, and mottling.
You have a vascular emergency. A thrombus, a blood clot, has likely formed at the insertion site and is blocking all blood flow down the leg.
You also need to push fluids post-procedure, right?
Yes. During the cath, the physician injects a radiopaque contrast dye to visualize the heart under fluoroscopy. That dye is notoriously nephrotoxic.
Meaning it hurts the kidneys.
It can shut down the kidneys if it sits in the system. As the nurse, you must flush it out. You maintain the IV fluids and aggressively encourage oral fluid intake to keep the kidneys perfusing and creating urine.
Let's zoom out to the general nursing management of an infant in congestive heart failure. A massive overarching theme here is energy conservation.
Think about the physiological state of an infant with a large VSD. Their heart is beating 160 times a minute just while they are asleep. They are breathing 60 times a minute.
They're essentially running a marathon on a treadmill that never stops.
Exactly. They have zero energy reserves. If you make them cry, you might push them into respiratory failure.
So we use a strategy called clustering care.
As a nurse, you cannot afford to be inefficient. You don't walk into the room at 8 a.m. to listen to their heart, wake them up, and make them cry.
Right.
Then come back at 8:30 to change a wet diaper, waking them up again. Then come back at 9:00 for medication.
You're just torturing a failing heart.
You cluster it all, you gather every single supply you need, you walk in, do a complete head-to-toe assessment, take vital signs, change the diaper, administer the oral medications, and initiate the feeding all in one seamless, organized block.
And then you turn off the lights and let them sleep uninterrupted for 3 hours.
Precisely.
Speaking of feeding, how do you nourish a baby who is too exhausted to eat?
The mechanics of feeding have to change. Sucking on a standard bottle requires massive effort. We use a soft, premature nipple, or we manually enlarge the hole in the nipple so the formula flows with minimal sucking effort.
And you feed them in an upright, semi-Fowler's position, right?
Yes, to take the pressure of their abdominal organs off their diaphragm, making it easier to breathe.
And if they still tire out after 5 minutes?
We don't force it. Feeding a cardiac baby should take no longer than 30 minutes. If they are still fighting after half an hour, they are burning more calories than they are consuming.
So we just stop.
We stop. To ensure they get enough calories, we fortify the formula. Standard formula is 20 calories per ounce. We might mix it to 24, 27, or even 30 calories per ounce.
And if they still can't take enough orally without going into respiratory distress?
We do not hesitate to drop a nasogastric tube, an NG tube, and pump the milk directly into their stomach. We give them the fuel without the workout.
Managing fluid status is also paramount, because a failing heart causes fluid to back up into the lungs and the body.
Strict intake and output is non-negotiable. You are weighing every diaper. But the most sensitive indicator of fluid retention is the daily weight.
Not a weekly weight, a daily weight.
Every single morning, on the exact same scale, at the exact same time, with the baby completely naked.
Because a weight gain of 50 grams in one day in an infant isn't fat, it is water weight.
Exactly. You are assessing for edema. In an adult, you look for swollen ankles. In an infant, gravity dictates that the fluid settles in the face.
You look for periorbital edema puffiness around the eyes.
You palpate the abdomen to check for hepatomegaly, an enlarged, congested liver. And you listen to the lungs for crackles, indicating fluid in the alveoli.
Which brings us to the pharmacology, the medications we use to manage this heart failure. Let's talk about the big three: digoxin, diuretics, and ACE inhibitors.
Okay, the big three.
I want to pause on digoxin because there is a concept here that feels incredibly unfair to pediatric nurses.
I think I know what you're going to say.
Digoxin is a cardiac glycoside. It has a positive inotropic effect, meaning it makes the heart muscle contract with much more force, and a negative chronotropic effect, meaning it slows the heart rate down.
Right, it makes the heart an incredibly efficient pump. But it has a terrifyingly narrow therapeutic index.
The gap between a dose that helps the baby and a dose that poisons the baby is microscopic.
Yes.
And the toxicity signs are what I find so frustrating. The study guide says the very first earliest sign of digoxin toxicity is vomiting. Vomiting.
I know.
Babies spit up and vomit all the time. It's literally their default setting. How on earth is a nursing student supposed to distinguish normal infant reflux from a lethal medication buildup?
It is incredibly difficult, which is why your assessment has to be so sharp. You are looking for a change in pattern.
A change in pattern.
If a baby normally spits up a little milk immediately after a feed, that's normal. But if a baby on digoxin suddenly starts forcefully vomiting an hour after a feed or refuses to eat entirely and is lethargic,
You must treat it as toxicity until proven otherwise.
you hold the dose and notify the provider to draw a serum digoxin level.
What are the strict rules for administering it safely?
You never, ever give digoxin without checking an apical pulse first.
And how do you do that?
You place your stethoscope directly over the point of maximal impulse on the chest, and you count the beats for 1 full uninterrupted minute. You are listening for the rate, and critically, you are listening for any new irregular rhythms, which is a later sign of toxicity.
The exam rule for holding the medication is very specific here.
You withhold the digoxin if the apical pulse is less than 100 beats per minute in an infant, or less than 70 beats per minute in an older child.
Now, a heart rate of 95 in an adult is totally normal. Why hold the med for an infant at 95?
Because cardiac output equals stroke volume multiplied by heart rate.
Okay, physiology time.
An adult heart is compliant. If it needs to pump more blood, it just stretches and pumps a larger stroke volume. But an infant's heart is stiff. It cannot increase its stroke volume.
So the only way an infant can maintain their cardiac output and perfuse their brain and kidneys is by keeping their heart rate high?
Exactly. If you give digoxin and knock their heart rate down into the 80s, their cardiac output plummets and they will go into shock.
Incredible. Okay, diuretics. Furosemide or Lasix?
Furosemide is a loop diuretic. It acts on the kidneys to aggressively dump sodium and water out into the urine, pulling that backed up fluid out of the lungs and the liver.
But furosemide is indiscriminate, isn't it?
Completely. Along with the sodium and water, it dumps massive amounts of potassium.
Hypokalemia, low potassium.
Hypokalemia is incredibly dangerous because it causes muscle weakness, and the heart is a muscle. It leads to lethal cardiac arrhythmias.
But here's the specific pediatric connection. Low potassium actually enhances the effects of digoxin, dramatically increasing the risk of digoxin toxicity.
Exactly. So if you are giving Lasix and digoxin together, which is very common, you are walking a tightrope. You have to monitor those daily electrolyte panels like a hawk.
You do. You encourage potassium-rich foods, or more likely, you will be administering oral potassium supplements, which taste awful, so you have to get creative with how you give them.
Definitely.
Finally, ACE inhibitors, like captopril or enalapril.
ACE inhibitors block the conversion of angiotensin I to angiotensin II, which is a potent vasoconstrictor. By blocking it, the blood vessels throughout the body relax and dilate.
This reduces the afterload.
Right. Afterload is the resistance the left ventricle has to push against to open the aortic valve. If the systemic vessels are tightly constricted, the afterload is high, and the weak heart has to strain.
If the ACE inhibitor dilates those vessels, the afterload drops. It is like opening up all the lanes on the highway. The heart can easily push the blood forward.
The nursing considerations for ACE inhibitors: because you are dilating the blood vessels, you watch for hypotension, specifically orthostatic hypotension. The child might get dizzy when standing up.
You also monitor for the classic side effect, a persistent, dry, nagging cough.
And unlike furosemide, ACE inhibitors can cause the kidneys to retain potassium, so you watch for hyperkalemia.
Wow, okay. We have spent all this time talking about a pump that can stretch, hypertrophy, and adapt to pressure changes. But what happens when you introduce a pressure problem into a part of the body that absolutely, structurally cannot stretch?
We are leaving the chest cavity and moving up to the skull.
Let's discuss pediatric brain tumors and increased intracranial pressure.
The transition from cardiac to neuro requires a major shift in how you visualize anatomy. Blood vessels can dilate, the heart muscle can thicken.
But the human skull, once the fontanelles and sutures fuse in childhood, is a rigid, unforgiving box. It is a locked vault.
And inside that vault, the real estate is strictly accounted for. There are exactly 3 things inside the vault: brain tissue, blood, and cerebrospinal fluid, or CSF.
And this brings up the Monro-Kelly hypothesis, right?
Right, which states that because the vault cannot expand, if one of those 3 things increases in volume, the other 2 must decrease, or the pressure will skyrocket.
So if a child develops a brain tumor, a 4th alien entity taking up space inside the vault, or if that tumor blocks the normal drainage of CSF, causing a backup, the pressure has nowhere to go.
The brain tissue gets compressed against the bone, the blood vessels get squeezed shut, causing ischemia.
This state is called increased intracranial pressure, or ICP.
And the clinical presentation is driven entirely by the mechanics of that pressure.
The hallmark sign that every exam loves to test is the headache and the vomiting. But it's not just any headache. It's specific to the time of day.
Right. The child will predictably complain of a severe headache right when they wake up in the morning.
Why in the morning?
Gravity. When you are standing upright during the day, gravity assists the venous blood and the CSF in draining out of your head and down into your body. But when you lie flat in bed for 8 hours, that gravity assist is gone. Venous drainage slows down.
For a healthy person, the slight rise in ICP is unnoticeable.
But for a child with a mass already taking up space, that slight nocturnal rise in pressure pushes them over the edge. They wake up in agony.
And the same mechanism drives the vomiting. They will often wake up, sit up, and forcefully vomit.
And crucially, it is not always preceded by nausea. It is not a gastrointestinal issue.
It's a neurological reflex.
The extreme pressure in the skull is physically compressing the vomiting center located in the brainstem. The body violently purges.
What other signs are we assessing for?
You see a loss of developmental milestones. A toddler who is walking perfectly starts stumbling, exhibiting ataxia or dropping their toys. You see vision changes.
Like papilledema.
Yes. The pressure inside the brain pushes down the optic nerve, causing papilledema swelling of the optic disc that the physician can see with an ophthalmoscope. The child might complain of double vision.
In an infant whose skull sutures haven't fused yet, the presentation is actually different, right?
Yes, because their vault isn't locked yet, the pressure will literally force the skull bones apart.
You will observe a bulging, tense fontanelle, the soft spot on the top of the head.
And if you measure their head circumference, it will be crossing percentiles, growing abnormally fast.
All of those are early signs. But if the pressure continues to rise unchecked, the body goes into a state of absolute physiological panic.
This brings us to a terrifying clinical picture: Cushing's triad.
Walk us through the exact mechanism of this triad.
Cushing's triad is a late ominous sign. It means the intracranial pressure is so incredibly high that it is cutting off arterial blood flow to the brainstem.
The brainstem is basically suffocating.
Yes. In a desperate final attempt to force oxygenated blood up into the highly pressurized vault, the sympathetic nervous system triggers a massive systemic vasoconstriction.
It clamps down all the blood vessels in the body to shoot the blood pressure through the roof.
Exactly. The systolic blood pressure skyrockets, but the diastolic pressure doesn't rise as much, leading to a widening pulse pressure. That is sign number 1, hypertension with a widened pulse pressure.
Sign number 2 is related to the heart rate.
Right. The baroreceptors in the carotid arteries sense this massive sudden spike in blood pressure. They panic, thinking the high blood pressure is going to blow out the vessels, so they trigger the vagus nerve to slam the brakes on the heart.
The heart rate plummets.
That is sign number 2, profound bradycardia.
So you have a skyrocketing blood pressure and a crashing heart rate.
And sign number 3, irregular depressed respirations. The pressure is physically crushing the respiratory centers in the medulla.
If you see Cushing's triad hypertension, bradycardia, irregular breathing, brain herniation is imminent.
The brain is about to be forced down through the foramen magnum, the hole at the base of the skull. It is a terminal event.
To prevent that, we take the child to surgery. Let's discuss the perioperative nursing care.
Preoperatively, your baseline neurological assessment is your most vital tool. You need highly detailed documentation of their pupil size and reactivity, their hand grasp strength, their gait, and their precise level of consciousness before the surgeon cuts into the brain.
Because when they come out of surgery, you need to know if a deficit is a temporary surgical complication or a new hemorrhage.
Exactly. We also administer drugs pre-op. We use dexamethasone, a very potent corticosteroid, to aggressively shrink the inflammatory edema surrounding the tumor mass.
The study guide also specifically notes administering stool softeners. I want to highlight this because it seems so mundane compared to brain surgery.
It is entirely about physics. Think about what a person does when they're constipated. They hold their breath, tighten their abdominal muscles, and bear down.
The Valsalva maneuver.
Right. When you bear down, you massively spike the pressure in your chest, which stops venous blood from draining out of your jugular veins, which instantly spikes your intracranial pressure.
For a child with a brain tumor, straining on the toilet could literally induce herniation.
It could be lethal. Stool softeners eliminate the need to strain.
Okay, the surgery is done, the tumor is out, the bone flap is replaced, and the scalp is sutured. The post-op care requires meticulous attention to positioning.
Positioning is your primary tool for manipulating ICP. Gravity is your best friend. You must keep the head of the bed elevated, usually to 30 degrees.
This promotes the venous blood and CSF to drain out of the head and back into the central circulation.
And the head and neck must be kept perfectly midline.
You can't let their head slump to the shoulder.
If the neck twists, you kink the jugular veins, trapping blood in the vault. And the absolute cardinal rule of post-op neurocare: never, ever elevate the feet.
Why? What happens if you do?
If you raise the feet, you increase the venous return to the right side of the heart, which increases cardiac output, which pumps more blood volume directly up into the fragile, swollen brain, spiking the ICP and increasing the risk of a blowout hemorrhage at the surgical site.
What about turning the patient to prevent bed sores?
If the surgeon performed a large craniotomy, meaning they removed a large section of the skull bone to access the brain, you generally do not position the child to lie on the operative side.
You have a massive hole in the rigid vault. You do not want the heavy weight of the brain shifting, sagging, and pressing against that unprotected surgical site.
Exactly, you turn them on to the unaffected side.
What medications are we using post-op to manage the inevitable swelling of the brain tissue itself?
We rely on osmotic diuretics, specifically IV mannitol or sometimes hypertonic saline.
How does mannitol work?
Mannitol is a sugar alcohol. When you infuse it into the bloodstream, it makes the blood incredibly concentrated, highly hypertonic. It does not cross the blood-brain barrier.
So you have this incredibly dense, salty, sugary blood flowing through the brain vessels.
Through the power of osmosis, it acts like a powerful sponge. It literally sucks the excess water out of the swollen brain tissue, across the blood-brain barrier, and into the blood vessels.
The swelling in the brain goes down, and then the kidneys filter out the mannitol and the excess water, and the child pees it out.
Exactly. But because you are dealing with the brain, and specifically the area near the pituitary gland, you have to be hypervigilant for water balance disasters. Manipulating the brain often pisses off the pituitary gland.
Leading to either SIADH or diabetes insipidus.
Right. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. The traumatized pituitary gland dumps massive amounts of ADH.
The kidneys get the signal to hold on to every drop of water.
The child stops peeing, the fluid backs up, the blood becomes diluted, sodium levels crash into dangerous hyponatremia, which can cause seizures, and the fluid overload spikes the ICP all over again.
And the opposite end of the spectrum is diabetes insipidus, or DI.
In DI, the traumatized pituitary stops making ADH altogether. Without ADH, the kidneys just open the floodgates.
The child will pee liters and liters of dilute, clear urine in a matter of hours.
They will rapidly go into severe dehydration and hypovolemic shock. As the neuronurse, you are doing strict hourly intake and output, measuring the specific gravity of the urine, and drawing frequent serum sodium levels to catch these shifts before they become fatal.
It is incredibly delicate. Even normal kid behaviors, crying because they miss their parents, shivering because the room is cold, or coughing, can dangerously spike their ICP.
Which is why maintaining a calm, dark, quiet environment, aggressively managing their pain, and controlling their body temperature with antipyretics are not just comfort measures. They are vital neuroprotective strategies.
We're going to pivot from a very localized mechanical cancer, a tumor compressing a closed box, to a systemic, whole-body battle plan. We are moving to pediatric oncology, specifically acute lymphoblastic leukemia, or ALL.
ALL is the most common pediatric cancer. Unlike a brain tumor, you cannot surgically cut all out. It is a cancer of the blood and the bone marrow. It is everywhere.
To understand the symptoms, we need to use an analogy for the pathophysiology. Let's think of the bone marrow, the spongy tissue inside the long bones, as the body's central blood cell factory.
I like that. A healthy bone marrow factory has 3 main assembly lines. Line 1 produces red blood cells, which carry oxygen.
Line 2 produces platelets, which act as the body's band-aids to stop bleeding.
And line 3 produces mature white blood cells, specifically neutrophils, which are the soldiers that fight off bacterial infections.
In a child with ALL, what goes wrong in the factory?
The factory gets hijacked by a genetic mutation. Instead of producing mature, useful white blood cells, the stem cells start furiously producing abnormal, immature, completely useless white blood cells called lymphoblasts, or just blasts.
So the factory assembly line goes haywire. It's stamping out millions of defective parts.
And these defective blasts do not die off like normal cells. They just keep multiplying.
Very quickly, the physical space on the factory floor, the bone marrow cavity, becomes completely packed wall to wall with these useless blasts. They crowd out the healthy assembly lines.
The normal production of blood cells grinds to a complete halt.
This factory shutdown creates the classic clinical triad of leukemia symptoms. Let's break them down. First, the factory stops making red blood cells.
The child develops profound anemia. Without red blood cells to carry oxygen, the child will present with crushing fatigue, lethargy, shortness of breath, with mild exertion and extreme pallor. Their skin and mucous membranes will look incredibly pale.
Second, the factory stops making platelets.
The child develops thrombocytopenia. Without platelets to form clots, the child becomes a bleeding risk. Parents will bring the child in saying, "He is covered in massive bruises and he hasn't even fallen down."
You will see prolonged bleeding from minor scratches, bleeding gums when they brush their teeth, frequent nosebleeds, and a classic sign called petechiae.
Describe petechiae.
Petechiae are tiny, pinpoint, non-blanching red or purple spots on the skin.
They happen because the microscopic capillaries in the skin are constantly experiencing tiny ruptures from normal movement, and without platelets to instantly plug them, they bleed slightly under the skin.
Third symptom. Despite the blood test showing a massive sky-high white blood cell count, the child is actually immunocompromised.
Because all of those millions of white blood cells are the useless defective blasts. The factory isn't producing any functional, mature neutrophils.
The child develops profound neutropenia.
They have no immune system. They will present with recurrent, stubborn infections, high fevers, and minor cuts that turn into raging cellulitis. A common cold virus can put them in the ICU.
The study guide also highlights a symptom that brings many children to the ER initially: severe bone and joint pain. A parent might think it's just growing pains. Why does leukemia cause such intense pain in the legs?
Because the bone marrow factory is physically expanding. Those millions of multiplying blast cells take up space. They pack into the medullary cavity of the long bones, and they begin to physically push outward against the inside of the bone.
The outer layer of the bone is called the periosteum, and it is densely packed with nerve endings.
The expanding marrow stretches the periosteum, causing a deep, unrelenting pressure-like agony in the bones and joints.
The diagnosis is ultimately confirmed by a bone marrow aspiration and biopsy, usually from the posterior iliac crest, the hip bone.
The pathologist looks at the marrow and sees that it is replaced by more than 20% blast cells. Once diagnosed, the treatment is systemic chemotherapy. The guide breaks this into 3 distinct phases.
Phase 1 is induction. This is the shock and awe campaign.
It involves intense, high-dose, multi-agent chemotherapy given over the first 4 to 6 weeks. The sole aggressive goal of induction is to obliterate the leukemia cells to the point where they are undetectable, achieving what we call a complete remission.
But remission in leukemia does not mean cured.
Not at all. Remission just means the blast count in the marrow is below 5%. But we know that microscopic, stealthy leukemia cells are still hiding in the body. If we stop treatment now, the cancer will roar back.
That leads to phase 2, consolidation or intensification.
What happens in consolidation?
This phase lasts for several months. We use different combinations of chemotherapy drugs to hunt down and eradicate those microscopic residual cells. We specifically target areas where leukemia likes to hide from systemic blood flow, particularly the central nervous system.
We will administer chemotherapy, intrathecally injecting it directly into the cerebrospinal fluid via a lumbar puncture to sanitize the brain and spinal cord.
And finally, phase 3.
Maintenance. This is the marathon. It lasts for 2 to 3 years. The child takes lower daily oral doses of chemotherapy, combined with periodic IV treatments, to keep the immune system suppressed just enough to prevent the leukemia from ever gaining a foothold again.
As a nurse administering these drugs, you have to understand that chemotherapy agents are essentially systemic poisons designed to aggressively target and kill fast-replicating cells.
They are highly toxic, and they do not differentiate between a fast-growing cancer cell and a fast-growing healthy cell. They destroy both. Because of this toxicity, safe handling by the nurse is a massive focus on the exam.
What are the protocols?
When you administer 5E chemo, you are wearing specialized, thick chemotherapy gloves, a non-permeable gown, and a face shield. But the safety doesn't stop when the infusion ends.
Those toxic metabolites are excreted in the child's bodily fluids, their urine, stool, and vomit, for 48 to 72 hours post-infusion.
If you are changing a diaper or cleaning up emesis, you must wear full PPE to protect your own skin and mucous membranes from absorbing the cytotoxic drugs.
Meanwhile, the chemotherapy is completely decimating whatever was left of the child's bone marrow. The child is plunged into a state of absolute neutropenia, an absolute neutrophil count, or ANC, of 0.
How do you protect a child who has literally no biological defense mechanisms?
We institute strict neutropenic precautions. Meticulous, obsessive hand hygiene is your primary weapon. Anyone entering the room washes their hands with soap and water. We completely restrict visitors. No siblings with the sniffles, no coughing grandparents.
And we aggressively alter their environment. We remove anything that could harbor bacteria or fungus.
Right.
No fresh, unpeeled fruits or vegetables that can carry soil bacteria. No raw meats. No fresh flowers in the room. No potted plants.
Why no potted plants?
Because the damp soil in a potted plant is a breeding ground for fungal spores, particularly Aspergillus. If a neutropenic child inhales an Aspergillus spore, it will colonize their lungs and cause a necrotizing pneumonia that is incredibly difficult to survive.
There is also a strict rule regarding immunizations for these kids.
A child undergoing chemotherapy, or any child who is severely immunocompromised, must never receive a live virus vaccine.
Like the MMR measles, mumps, rubella, or the varicella chickenpox vaccine.
Correct. Those vaccines contain a living, albeit weakened, version of the virus. A healthy immune system easily defeats the weakened virus and builds antibodies, but a neutropenic child has no immune system.
If you inject them with the weakened MMR virus, The virus will multiply unchecked, and you will literally give the child a fatal case of measles.
We mentioned earlier that chemotherapy indiscriminately attacks all fast-growing cells in the body. It targets the hair follicles, leading to alopecia.
But much more severely, it targets the rapidly dividing epithelial cells that line the entire gastrointestinal tract.
From the lips all the way down to the anus, the GI tract is stripped of its protective lining. This causes a devastating side effect called mucositis.
The oral form, stomatitis, is particularly agonizing. The child's mouth, tongue, and throat become covered in raw, bleeding, ulcerated sores.
They cannot chew, they cannot swallow, their saliva becomes thick and ropey. They often stop speaking entirely because the movement of their tongue against the ulcers is too painful.
It puts them at massive risk for dehydration and severe malnutrition right when their body needs calories to heal.
How does the nurse manage a mouthful of ulcers?
Your care must be incredibly gentle. We abandon regular toothbrushes and use ultra-soft, disposable sponge swabs to gently clean the teeth.
We absolutely forbid any commercial mouthwashes that contain alcohol, which would feel like gargling battery acid. We alter their diet to be bland, soft, and non-acidic. No orange juice, no tomato soup, no salty potato chips. Think room temperature puddings, mashed potatoes, and milkshakes.
The SETI guide brings up a pharmacological intervention called Magic Mouthwash.
Magic Mouthwash is a custom compounded prescription rinse. The recipe varies, but it typically contains an antacid, like Malex, to heavily coat the sores and protect them from stomach acid if there is reflux.
It contains an anesthetic, like viscous lidocaine, to numb the nerve endings.
And it often contains an antihistamine to reduce inflammation and an antifungal, like nystatin, because those open, raw sores are prime targets for oral thrush infections.
You have the child swish and spit, or for a younger child, you gently swab it onto the sores. It provides a temporary window of numbness where the child might be able to tolerate drinking a nutritional supplement.
We have discussed the deep, pressure-like pain of bone marrow expansion and the sharp, burning agony of mucositis.
Managing pain appropriately, effectively, and compassionately is a core competency that defines a great pediatric nurse. Let's explore the complexities of pediatric pain assessment and management.
Pain assessment in adults is straightforward. You ask them to rate their pain from 0 to 10. But in pediatrics, you are dealing with patients who might be preverbal, cognitively delayed, or developmentally uncooperative.
The concept of 7 out of 10 means nothing to a 2-year-old.
You must use specific, validated, age-appropriate assessment tools.
Let's start with the youngest demographic. Infants, toddlers up to about age 3, or any older child who is nonverbal or cognitively impaired. The standard tool here is the FLACC scale. FLACC.
The FLACC scale is an observational tool. The nurse acts as an objective observer, scoring 5 categories from 0 to 2.
F is for face. Is the infant's face relaxed and smiling? Or are their eyebrows furrowed and jaw clenched in a grimace too?
L is for legs. Are their legs resting normally, 0, or are they rigidly drawn up tightly to their abdomen, 2?
A is for activity. Are they lying quietly, or are they thrashing, arching their back, and squirming, 2?
C is for cry. Are they quiet, 0, moaning, 1, or screaming continuously, 2?
And the second C is for consolability. If you pick them up, give them a pacifier, and rock them, do they calm down, or are they completely inconsolable regardless of what you do, too?
You add up the numbers, and it gives you a reliable, objective pain score out of 10.
As the child develops cognitive reasoning, usually between ages 3 to 7, we transition to a self-reporting tool, the Wong-Baker Faces Scale.
This is the iconic visual scale. It features a line of drawn faces. It starts on the left with a bright, smiling face representing 0 pain. It moves through a mildly frowning face, a deeply frowning face, and ends on the right with a face that is crying tears representing a 10, or the worst pain imaginable.
The nurse explains the scale, and the child simply points to the cartoon face that matches how their body feels on the inside.
And finally, for children over the age of 7 or 8 who firmly understand the concept of numbers, sequencing, and graduation, we can utilize the standard numeric rating scale, asking them to rate their pain from 0 to 10.
However, with older school-aged children, and specifically adolescents, relying solely on the 0 to 10 scale introduces a massive psychological complication. They have the cognitive ability to perfectly quantify their pain, but they frequently make the conscious choice to lie about it.
I really want to extol this because it drives nurses crazy. Why on earth would a 15-year-old who just had a massive spinal fusion surgery and is clearly in absolute agony look the nurse in the eye and say, "My pain is a 2 low, I'm fine"?
You have to look at the developmental psychology of a teenager. Adolescence is a stage defined by a desperate need for control, autonomy, and managing peer perception. There are many reasons they underreport.
First, fear. They might associate admitting pain with getting an intramuscular injection, which terrifies them.
Second, fear of side effects. Opioids can make you feel groggy, out of control, or nauseous. A teenager hates feeling out of control of their own mind.
Third, ego. They might believe that admitting they need pain medication makes them look weak, uncooperative, or like a baby, especially if their parents or friends are in the room.
And fourth, sometimes they just want the nurse to stop bothering them so they can go back to sleeping or texting.
So as the bedside nurse, how do you navigate that? If a teenager tells you their pain is a 2, but you look at the monitor and their heart rate is 135, their blood pressure is elevated, they are sweating, and they haven't uncurled from the fetal position in 3 hours, what do you do?
You have to be a compassionate detective. The golden unbreakable rule of nursing is that pain is whatever the experiencing person says it is. You cannot document, patient is lying, pain is innate. You must validate their self-report.
However, you gently confront the clinical discrepancy. You pull up a chair, sit at eye level, and say, I hear you telling me your pain is a 2, but I also see that you are breathing really fast, you are sweating, and you haven't moved your legs all morning. When your body is fighting that much pain, it takes away the energy you need to heal your incision. My job isn't to judge you, my job is to help you heal faster. Let's try some medication.
You educate them, build trust, and offer control. Let's talk about the interventions we offer. The gold standard is a multimodal approach, combining non-pharmacologic and pharmacologic therapies.
Non-pharmacologic interventions are incredibly potent in pediatrics. Never underestimate the power of distraction. A child's brain has a limited capacity to process stimuli.
If you flood their brain with a video game, an interactive light-up toy, blowing bubbles, or a virtual reality headset, you physically block the pain signals from reaching conscious processing.
For infants, the guide mentions swaddling, non-nutritive sucking with a pacifier, and oral sucrose.
Oral sucrose, or Sweet Ease, is a game changer for procedural pain, like an IV start or a heel stick in neonates. Just 2 minutes before the needle poke, you dip a pacifier in the sugar water.
The sweet taste on the tongue actually triggers the rapid release of endogenous endorphins in the infant's brain, providing brief but highly effective natural analgesia.
When medications are required, we follow the World Health Organization's stepwise approach.
Start low and go slow. For mild pain, we utilize acetaminophen. For mild to moderate pain, especially if it involves inflammation like a broken bone or surgery, we use NSAIDs like ibuprofen or ketorolac.
And for moderate to severe acute pain, we step up to strong opioids like IV morphine, fentanyl, or hydromorphone.
And when we mention opioids in pediatrics, we immediately crash into a wall of deeply ingrained, dangerous myths. We need to systematically bust these myths because believing them leads to horrific patient suffering.
Myth number 1, which shockingly still persists in some corners of medicine. Infants, especially premature neonates, don't really feel pain because their nervous systems are too immature.
This is biologically false.
It is entirely false. Anatomically, the peripheral nerve endings and the pain pathways up the spinal cord to the brain are fully intact and functional by the 3rd trimester of fetal development. An infant absolutely feels the needle cut their skin.
But here is the terrifying part. While their pain transmission pathways are formed, they're descending inhibitory pathways. The nerve tracts from the brain that release serotonin and endorphins to dampen and block pain signals are not fully developed until much later.
So not only do they feel pain, they actually lack the biological brakes to slow the pain down.
Exactly. A painful stimulus likely feels significantly more intense to a premature neonate than it does to an adult.
Furthermore, we now have robust neurological data proving that leaving severe pain untreated in neonates causes toxic stress that physically alters their brain architecture, leading to long-term cognitive and behavioral deficits. Treating infant pain is a neurological mandate.
Myth number 2. Administering potent opioids to children will cause them to become addicted. This fear paralyzes a lot of parents and, unfortunately, some nurses.
It is a profound and tragic misconception. We must separate physical dependence from psychological addiction. If a child is on a morphine drip for 2 weeks after a bowel resection, their body will become physically dependent. If we stop the drip abruptly, they will experience physiological withdrawal symptoms. That is normal biology. We manage it by slowly tapering the dose.
But that is not addiction.
No. Addiction is a complex psychological and behavioral disorder characterized by compulsive drug-seeking behavior despite catastrophic harm. When opioids are used appropriately, rigorously dosed for acute, severe, tissue-damaging pain like major surgery, a sickle cell vaso-occlusive crisis, or terminal cancer, the risk of a child developing true psychological addiction is vanishingly, incredibly minimal.
Withholding necessary, ordered pain medication from an agonizing child out of an unfounded fear of creating an addict is cruel, unethical, and violates the core oath of nursing.
Myth number 3. You should wait until the child explicitly asks for pain medicine, or until the pain becomes severe before you administer a dose.
This is the chasing the pain fallacy. It is a recipe for disaster. You must treat pain proactively.
Think of pain like a fire. It is infinitely easier to stomp out a small campfire than it is to extinguish a raging forest fire.
If you wait until a child's pain is a 9 out of 10, their nervous system is heavily sensitized. A standard dose of morphine won't even touch it. You will have to give massive, sedating doses to wrestle it back under control.
Anticipate the pain.
Always. If you know a child is scheduled for a painful burn dressing change at 10 a.m., you do not wait for them to start screaming when the tape comes off. You walk into that room at 9:15 a.m. and administer their oral or IV analgesia so that it reaches peak therapeutic effect right when the nurse pulls the tape. Proactive, scheduled pain management is always superior to reactive pain management.
Managing a child's physical pain is exhausting and demanding work. But as a pediatric nurse, there will be days when all the surgeries, the chemotherapy, and the interventions fail. You will have to guide families through an entirely different, unfathomable realm of suffering.
You have to guide them through grief, and you have to help young children navigate the concept of death. Let's move to our final topic, the hardest part.
This is the material that tests not just your clinical memorization, but the depth of your humanity. The most crucial concept for your exam and for your survival on an oncology or ICU unit is understanding how a child conceptualizes death.
Their understanding is not based on their intelligence. It is based strictly on their developmental stage of cognitive psychology. It changes radically as their brain matures.
Let's start from the beginning. Infants and toddlers, from birth to about 2 or 3 years old. How do they understand death?
Cognitively, they don't. At this age, there is absolutely zero conceptual understanding of death. The word forever means nothing to a toddler. However, this does not mean they don't grieve. They are acutely, intimately aware of separation.
They react to the absence.
If a primary caregiver dies, or if their sibling vanishes from the house, the toddler reacts to the profound disruption of their daily routine. Furthermore, toddlers are emotional sponges. They absorb the overwhelming sadness, anxiety, and weeping of the surviving adults in the room.
They react to the chaos. You will see them regress in their milestones. A potty-trained toddler will start wetting their pants again. They may become intensely clingy, suffer from severe separation anxiety, or cry incessantly without being able to articulate why.
Moving to preschoolers, roughly ages 3 to 5. This is perhaps the most delicate and psychologically dangerous stage to navigate as a nurse.
It is incredibly tricky. Preschoolers operate firmly in a world of magical thinking. In their minds, the lines between reality, cartoons, and dreams are blurry. To a preschooler, death is not permanent. They view it as a temporary state. It is reversible.
They think of it like a long nap.
Exactly.
Yeah.
They fully expect the deceased person to wake up or to come back from wherever they went. They might ask, "When is Mommy coming back to make me breakfast?" Weeks after the funeral. Because of this, the language you use as a nurse is absolutely vital.
You cannot use euphemisms.
You must strip away all the softening language that adults use to comfort themselves. If you look at a 4-year-old and say, "Grandpa went to sleep peacefully," you have just instilled a terrifying phobia of going to bed in that child. They will think if they fall asleep, they might never wake up.
If you say, "We lost your brother today," the child will look at you logically and expect you to go out into the hallway and find him.
It feels incredibly harsh to say it, but you have to use the literal words.
You must use the words died and dead. You explain simply, his body stopped working, his heart stopped beating, he is dead, and he cannot come back. It is brutal for the adult to say, but it provides necessary, concrete clarity for the child's developing brain.
There is also a severe risk in this age group regarding guilt.
This is the darkest side of magical thinking. Preschoolers are profoundly egocentric. They believe the entire world revolves around them, and more importantly, that their thoughts can cause real-world actions.
If a 5-year-old gets angry because their sibling broke a toy and yells, "I hate you, I wish you would go away," and then a week later that sibling dies in a car accident,
The preschooler connects those two events.
in their mind, it is a direct causal link.
Yeah.
My bad thought killed my sister. This is my fault. The guilt is crushing.
As a pediatric nurse, you cannot wait for them to express this because they often won't. You have to actively, preemptively dispel that magical thinking. You sit down, look them in the eye, and say, the doctors tried everything, your sister's body was too sick, this happened because of a disease, nothing you said, nothing you thought, and nothing you did caused this to happen. It is not your fault. You have to repeat it until they believe it.
Okay, school-age children, roughly ages 6 to 12.
This is a major cognitive turning point. Sometime around age 7 or 8, the permanence of death finally clicks. They understand that death is final, it is irreversible, and it is universal, meaning it happens to every living thing, including plants, animals, and people.
But the guide notes a caveat. While they understand it universally, it doesn't always feel personal to them.
Right. They understand that death happens, but they conceptualize it as something that happens to other people, old people, sick people, not them. But they are intensely logical, concrete thinkers. When death enters their orbit, they cope by seeking information. They become intensely curious about the physical, biological details.
They ask the uncomfortable questions.
What happens to the body in the dirt? Are there bugs? How did the heart actually stop? Does it hurt to be cremated? Adults recoil from these questions, thinking the child is being morbid. They aren't. They are just trying to build a mechanical understanding of an abstract terror.
As a nurse, you answer these questions factually, honestly, and scientifically, without being overly graphic. Satisfying their curiosity reduces their anxiety.
And finally, adolescence, ages 13 to 18.
Adolescents have a fully mature, adult-like conceptual understanding of death. They know it's final, universal, and inevitable. But developmentally, their brains are wired for risk-taking and feelings of invincibility. They're just discovering their identity and planning their futures.
So when death intrudes, whether it is the sudden death of a classmate or their own terminal cancer diagnosis, it violently shatters that illusion of invincibility.
And their emotional reaction can be volatile.
They can react with explosive anger at the unfairness of it all. They can plunge into deep depression or grapple with profound existential questions about religion, purpose, and the meaning of life.
But often, they hide it.
That is the tragedy of the adolescent patient. They often feel a burden to protect their parents. They will smile and act brave while the mother is crying in the room, or they will mask their terror to maintain their cool persona in front of visiting friends.
They desperately need peer support groups, and they need nurses who treat them as near adults. You don't talk down to them. You offer them brutal honesty, immense respect, and you ensure they have a voice in their own end-of-life care decisions.
When a child is actively dying on your unit, what are the primary nursing interventions for the family in the room?
Your role shifts from curative to supportive. You provide a safe, private, non-judgmental space. You ensure the child's physical pain and air hunger are aggressively managed so their passing is peaceful. You actively support the siblings, who often become the forgotten mourners, sitting quietly in the corner while the parents are understandably consumed by the dying child.
You also facilitate anticipatory grief and memory making.
You don't wait for the child to pass. While they are still here, you offer the parents the chance to cut a lock of hair. You bring in plaster and help them make handprints and footprints of the child. You offer to help the child write letters or record videos for their parents to watch later. You are building the physical artifacts that the parents will cling to for the rest of their lives.
There is one more concept about children in grief that I think is a profound insight, and it's something every new nurse needs to understand to avoid judging a family. Children process grief in bursts.
They do. Adults tend to drown in grief. When an adult loses a child, the grief is a constant, suffocating heavy weight that presses down on them every second of the day. A young child's brain simply cannot sustain that level of intense, exhausting emotion for long, uninterrupted periods. They have to take breaks.
So they will be crying hysterically at the funeral service.
And 10 minutes later, you will see them running around the reception hall, laughing and playing tag with their cousins. And a grieving parent or an inexperienced nurse might look at that child and think, what is wrong with them? Do they not care that their sister just died?
It looks callous.
But it is a perfectly normal, necessary, protective psychological mechanism. It is clinically referred to as puddle jumping. The child jumps into the puddle of grief, they feel the sorrow intensely, they cry, and then their brain says, that's enough, I can't take anymore. So they jump out of the puddle into play to cope and recharge. Later they will jump back into the puddle. As the nurse, you must educate the horrified parents that this is normal, healthy behavior. You reassure them that the child is not broken.
That brings us to the end of an incredible, massive journey through pediatric nursing.
It is a lot to carry. We started with the physical pressure gradients of the heart, understanding why blood shunts to flood the lungs or bypasses them to cause cyanosis. We walked through the painstaking care of a failing infant heart, the rigid physics of the skull and intracranial pressure, the systemic collapse of a leukemia-filled bone marrow, and the relentless toxicity of chemotherapy.
We analyzed the subtle, age-specific ways children express physical agony, and we busted the dangerous myths surrounding pain management. And finally, we faced the heavy reality of guiding families through the developmental labyrinth of grief.
It is the most challenging nursing specialty in the hospital.
It is. And to the nursing student listening to this right now, rubbing your tired eyes and looking at that study guide, I want to leave you with one final thought. You have spent hours memorizing milligram per kilogram medication dosages. You have memorized the sequence of Cushing's triad, the normal lab values for platelets, and the exact angle to position a post-op craniotomy bed. You are doing all of this to pass a grueling final exam.
But I want you to step back and look at the bigger picture. Look at what connects all of these disparate facts. A child's magical, fearful concept of death. Their complex, sometimes deceptive behavioral reaction to severe pain. The literal mechanical way their tiny malformed heart routes blood just to survive another day. All of these things are connected by their intense, profound vulnerability.
When you finally pass that exam, and you will, and you step onto the pediatric floor in your scrubs for your very first shift as a registered nurse, you are not just treating a diagnosis scribbled on a chart. You are taking the terrifying, sterile, high-pressure adult world of modern medicine, and you are translating it. You are translating it into a language that a 3-year-old hiding under their blanket, a hostile 15-year-old, and their utterly exhausted, terrified parents can actually understand and trust.
You are the buffer between the cold reality of the X-ray machine and their fragile humanity. You are the one who notices the vomiting isn't reflux. You are the one who advocates for the morphine. You are the one who explains the puddle jumping. That translation, that advocacy, that empathy, that is the true, beautiful art of pediatric nursing. Good luck in your final exam. You have the knowledge. You have the understanding. You are going to be an amazing nurse.